This conference will now be recorded.
Here we go. Okay, welcome to another episode. Today we're talking about personality disorders, part 1, borderline personality disorder. The first thing I want to say is with borderline personality disorder is that the stigma associated with it is terrible. And often if a clinician becomes frustrated with a client, especially if it's a female, they might say, oh, she's a borderline, or, oh God, it's borderline, and the stigma associated with it is awful. And it does reflect on the client, it reflects on the staff or the clinician as judgmental, condescending, and uninformed, really. And I've done it over the last 30 years, of course, I don't think anybody is immune, but it really does need to be addressed differently. So the general definition of a personality disorder is that it's pervasive and inflexible, meaning that the features tend to be ongoing and more long-standing, and the inflexibility is that often a lot of the symptoms are just very fixed and very concrete, and you'll see that in the person. The symptomology, many people may think it's volitional or purposeful, but it really is an extension of distress. And a lot of people don't want to believe that, like I said, they think it's behavioral, but it really is, it leads to distress and impairment as well, the more that it takes place. So borderline personality disorder is considered a cluster B personality disorder, and it's in there with histrionic, narcissistic, antisocial. And the reason that it's cluster B is because it's based in very emotional responses, erratic behavior, and extremely dramatic. And so that's why it's considered cluster B. So with borderline personality disorder, one of the biggest things that clinicians will exhibit as a result of having a lot of contact with a client like this is irritability, because boundaries are pushed, tolerance is pushed, patience is pushed, and the belief that these behaviors are purposeful really adds to that. And then you have issues with boundaries that we'll talk about in a little bit. Some are hard to avoid, but they need to be avoided.
I have a client who doesn't have a personality disorder access 1 diagnosis, but has access to the cluster B traits.
Cluster B traits.
So what is the difference? Why does she have the access to is cluster B traits, but she doesn't have a personality disorder diagnosis on access 1?
Probably because how old is she? Right away I say she because
4. She's real good.
We were just talking yesterday about how long have you known her?
I've been working with her for almost 6 years.
Okay. Have you seen improvement?
In terms of
like behaviors, responses, anything like that? Has she simmered down any?
Oh, well, with me she has, only because it's been so long and I know the tricks and and all.
And the reason I ask is because borderline personality disorder is one of those where as people age, they tend to show characteristics of almost aging out of it. It can become less acute. But traits versus a full diagnosis, if it's not pervasive, long-standing, and evident very continuously, it's not going to meet criteria of a disorder. Traits are going to be more things that exhibit themselves that don't directly interfere with functioning on a consistent basis. Does that make sense? Mm-hmm. So somebody who's diagnosed with borderline personality disorder, their baseline functioning is real erratic, on a pretty consistent basis. Make sense? Okay. Does that help? Mm-hmm. Okay. So 93% of women, and it's primarily women that are diagnosed with this, have some type of traumatic history. some type of trauma history. Sexual abuse is very common. Physical abuse, even like neglect. Neglect can have a big impact because you tend to very dramatically pursue what you need later in life for fear of not having it. Does that make sense? So trauma is true usually across the board, some type of trauma, with sexual abuse being very common. It is primarily a disorder of the female gender, although not exclusively. So I would venture to guess that some clinicians only see females with borderline personality disorder in their careers because clinicians are reluctant to diagnose a male with borderline personality disorder. You're often going to see something else. You're going to see a conduct disorder. You're going to see antisocial traits, which are also in cluster B, which can be really dramatic. So they tend to be a little more reserved in their diagnosis with males for this. So the borderline personality disorder, the number one mark is instability in interpersonal relationships. And it's marked. It shows difficulty establishing relationships, maintaining relationships, establishing healthy boundaries within relationships, and understanding that sometimes factors within relationships can be one-sided. If I help you carry your groceries into the house, it's not with an automatic response that you're going to do something for me. In borderline personality disorder, it often is. And that's reserved for later. Well, I carried your groceries into the house. Now I need you too. And it's not a volitional act of wanting to trap somebody into doing something for them. It's just believing that all relationships are constantly two-way. And if I feel this way, or if I do this for you, then you're going to automatically react the same way to me. Because that's the reference I have. So the instability in personal relationships, you're going to really see that often families either become super enmeshed or super detached. Because if the family members have fewer personal issues of their own, their frustration is going to go like this. If they're really enmeshed with the person from the beginning, it might become more so. Because clinicians coming from the outside, and this has just been my experience at Winnebago, is that if family members are very enmeshed with somebody who's borderline personality disorder, and you come in and challenge the behaviors of the personality disorder, the family is going to come in and try to save that person and say, well, this is who she is because of A, B, C, D, and kind of tend to justify the behaviors, or they're in a position where they just see no possibility of change. She's been like this for so long that she's not going to change, or we can't change her, or so keeping those kind of things in mind. So the person with borderline personality disorder is often pursuing avoidance of abandonment, and it might be real and it might be imagined. Okay, so with a traumatic history, the one thing you don't have is constant or consistent security. So when relationships come and go, it's going to rock the world, because in order for me to function, I need some type of connection, usually at all times, no matter what it's going to take. And as we go on, we'll talk about like the negative ways, that attention is sought, relationships are sought, interventions are sought. And as a person gets older, there are some healthier ways. So there's intolerance of being alone. And a lot of that is fear-based. And the need for people to be with them is because of the insecurity in a self-image or not having an idea of who I am, an identity. So I'm defined by those outside of me, okay? I am who you think I am. So the basis can often be I'm bad. So if a caregiver or clinician gets frustrated with me, then that reinforces I'm bad, okay? If somebody's boundaries cross with me, there's lack of trust because I'm bad. Do you see what I mean? There's often not the possibility or the reference to say, well, if you do nice things for me, it's because maybe I did something good. There's no reference for that. And so we'll talk about that more as we go on. Does that make sense? Okay. So instability in mood is a characteristic that is across the board evident in someone with borderline personality disorder. And the reactions are extreme, very dramatic. It's either attachment or rejection, it seems, in the person, where if you're nice to me, I'm going to attach like a leech. I'm just going to like that. And if you challenge me, it's going to go like this, and I'm going to get angry. So there's, we've heard about love, hate, love, hate. Well, it's really true. It's extremely concrete. I love you or I hate you. You love me or you hate me, but there's expectations on both sides for both parties. So if I love you, there's expectations of what I'm going to do, but there's expectations about how you're going to respond. If I hate you, I have expectations about how you're going to respond, and then that's going to prompt my reaction, which would, in my mind, would be justified. So the reactivity, it's love, hate, react. It's love, hate, attachment, rejection, always, never. The other one I want to really point out is always, never. Because if you challenge me, one of the statements you may hear is, you're always giving me a hard time, because that's what sticks out. If you may say, nope, you can't do that today, you never let me do anything. And if you think about it, it's an immature stance. Kids are very concrete. And so that hasn't expanded. But it's also based on the fact that I have no reference to gray. Okay.
Do you see a lot of people coming out of like foster care, well, I guess more specifically foster care, adoptions, whatnot, but have the diagnosis of RAD, where it might actually be this?
I don't have a ton of experience with that. At Winnebago, a lot of the kids that were admitted into YSU that may have been in those type of placements, that diagnosis was very common, extremely common. But at a young age, you have to be careful, because you don't want to diagnose something like a straight personality disorder, much like you wouldn't want to diagnose a child with schizophrenia, and so that may be a reason why I didn't see a lot of that. I saw very few kids that ever carried a diagnosis of personality disorder. It was often attachment reaction. It was attention deficit. It was
ODD.
It was I can't think of the other one, but the aggressive. I can't remember. So, but not personality disorder real commonly. That's often reserved for adults. If you look in the DSM-5, under the criteria for borderline personality disorder, they do not mention juveniles. But they don't say you can't diagnose a juvenile. It's just not real common practice. Okay. So anger is often inappropriate and extremely intense. Extremely intense. And this is where dangerous behavior comes in. If in the inpatient setting, a reaction like that in a closed environment with a lot of people around is going to increase the chance of assaultive or self-harm behavior, okay? Because a lot of attention is given to it. Even indirectly, just by a day room full of patients, you know. So in the outpatient setting, it's often presents a little different, which we'll talk about, but within a group home setting, and in the community, it's often very explosive. It can be very intense, and it can be long-standing, you know, where I'm mad at you right now, and I'm going to keep that in my circular file for when you try to do something nice. I can refer back to this and say, but you did, and then I get angry all over again. Does that make sense? So the anger and the difficulty controlling the anger is huge because it interferes in all areas of functioning. It interferes with my independence. It interferes with my dependent behavior. It interferes with my relationships. It interferes with my time alone. It interferes with productive behavior, work, self-care, all these things. So it gets into every area of life, plus into the area of life of the person that's the target of it or the secondary target. And you got to keep in mind secondary targets, because with that level of anger, if your shift ends and you leave, there's somebody coming in that's going to still be a scapegoat, chances are, because I need to talk about you, you know. So, and that's where the limit testing and the relationship boundaries, that can be a huge thing. Because if a client is angry at me, I leave after first shift and somebody comes in and the person says, look at what this person did to me, blah, 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 blah. If there's so much as oh, wow, you know, that must have really been hard, bang, they got you. Okay. And then that's going to cause a split in the relationship with the person who left after first shift. Okay. So you're fueling the fire without even realizing it. Okay. By me saying that was really hard for you, in that person's mind says, see, I was right. This is what they did. It was hard for me. Does that make sense?
Mm-hmm.
So, okay. So anger is huge, but the anger, it's often followed by apology or shame or guilt, you know, and unconsciously, it's a setting up of the relationship for the agenda again. Okay. I didn't mean to yell at you. I didn't mean to do this. You know, if I just wasn't so stressed, it wouldn't have happened. Okay. But also it goes back to, aside from that, it goes back to the fact that I'm bad. Okay. I'm terrible. I'm a bad person. So I did this. And so it's that self-deprecating, I did wrong, I did wrong, I did wrong, and I'll apologize, but does it change a lot? No, it doesn't. So,
as a matter of fact, I would say I have never seen a lot of them do the apology part.
mm-hmm.
It's the lashing out, then the kind of quiet, and back to lashing out.
Okay. And yeah, in the inpatient environment, we saw that a lot, but often it was, I think, connected to canteen, courtyard, privileges, things like that. So it was like secondary gain, you know, so I should have clarified that. I think it was attached to secondary gain where I was most often. But yeah, I mean, absolutely. That quiet is kind of like the calm before the next storm. You know, is that what you're talking about? So, so consistently there's an instability in self-image, okay? And in talking about that a little bit, if I have no sense of self, you define me in the moment, okay? So that's where the real concrete love, hate, good, bad, that's what reinforces that. If I am what you think I am, and you tell me I'm doing a good job, you care about me, okay? If I am what you think I am, and you tell me you need to do that over because you didn't do it correctly or you didn't do it effectively, that's going to be what defines me in the moment. But then you take the two of you, and I'm going to create a split, okay? And that is so common, to split staff, to split family members. You'll just see that so often. And it's because I always want to keep somebody in my court. And it may be for internal reinforcement because I think I'm bad. It might be for external reinforcement. In the moment, it might be for secondary gain. I want to get my canteen this afternoon. But you're going to see that a lot, the splitting of people in relationships. And it's torn families apart. I mean, I've watched it tear families apart. And that's really just unfortunate. But often families have education on schizophrenia or bipolar disorder. You don't see too much education on borderline personality disorder and things like that. So even if you look at NAMI in their education programs, you're going to see schizophrenia, bipolar disorder. You're not going to see borderline personality disorder, antisocial personality disorder. So there's a disconnect there. Okay. So there's little sense of individual identity. So I'm often identified with those around me. Okay. The other thing too is that when somebody who truly has borderline personality disorder acts, 9 times out of 10, it's going to be real impulsive. Planning is not a skill of someone with borderline personality disorder. Not to say that they can't premeditate things. Does that make sense? But just planning, functional planning is often not a piece of the cards, because if something happens within that, I'm going to react. So it doesn't work to plan consistently. If I make an appointment with you as your therapist and I say next Wednesday at 9, and then on Tuesday afternoon, daycare is closed on Wednesday because there's a snowstorm, there's a chance all hell could break loose. And that person's going to react because it has to do with them. It doesn't have anything to do with anything else. And you told me last week that we were going to meet Wednesday at 9. And all or nothing, black and white, concrete. When you say something, that's what it is. So that's where skills training and stuff really comes in, that we'll talk about a little bit. Okay. So most often, self-harm, suicidal acts, not uncommon. Okay. Usually very impulsive and a reaction to some kind of emotional upset. And we see this with a love-hate relationship. We see it with all or nothing. So about 8 to 10% of people with borderline personality disorder actually complete suicide. Okay. Within that, and they don't have an exact percentage, but within that, there is a percentage of accidental suicides. Okay. Where it can be, there might be statements made, letters written about intent to commit suicide, but something happens and that's the trigger. Okay. And again, it goes back to that absolute and that impulsivity. But 8 to 10%, I mean, 10% is a lot. And so you need to really don't disregard statements of self-harm or suicide. You can't because of that possibility. But there's certain ways you can address it too. You don't have to entertain it real long to address it, if that makes sense. And it's part of it is liability. I mean, that's just part of the system. You have to address it for certain reasons. But how you address it can often make a difference. So talking about that, because of the concrete thinking, and somebody says, I feel suicidal, often rather than saying something like a QPRT where you say, do you have thoughts of suicide? Do you have a plan? Those things are important, but often it's helpful to shift the thought patterns to, well, what were you thinking you wanted to do later today? Or, if you ask me, who loves you the most, I'm probably not going to be able to come up with it. Okay. But if my family is bringing my dog for a visit at Winnebago at 3 o'clock, that counts. Okay. Because it's not a person-to-person attachment. Does that make sense? It's almost like indirect reinforcers can be most helpful during acute statements of suicidality rather than personal attachment, because it's love and it's hate, okay? Or it's all or it's nothing. You can use somebody that they have in their focus as a support, as loving them, absolutely. You know, sometimes a phone call makes all the difference to a family member or a provider or a case manager, but you got to be really careful about boundaries when you're including staff. But you can't ignore it. You can't ignore it. And one thing that is often a mistake made is that because of the nature of the diagnosis, people don't take those kind of threats seriously. You're just saying that because you're mad at me, or she's borderline. She always does this when she doesn't get what she wants. And that's one of the biggest mistakes you can make, because all of a sudden somebody completes suicide, whether it be very impulsively as a reaction or accidentally, in a gesture, in an impulsive gesture or dramatic gesture, their thoughts are still valid. And so you need to honor that. Which is hard because there's a line, you know. Part of it is knowing the client's patterns. And I say patterns because you don't have to know somebody emotionally to recognize their patterns. Does that make sense? And those can be tools for us. Behavior patterns, reactionary patterns, patterns of escalation, things like that. Paying attention. One of the things that we talk to new employees about at Winnebago is look at their surroundings, look in their room, because you're going to see what makes a difference. Okay. What is placed in the room is often a reinforcer for the internal stuff, and the behavior is an extension of external stuff. Does that make sense? You look confused, Bill.
Explain it another way.
Okay, so if I'm at Winnebago and I look in a patient's room, okay, she's 37 years old and she's got stuffed animals all over the place. Okay, that's for something internal. Okay, if I have the rules and the unit guidelines in my room, I'm probably not going to look at it. Okay, because it doesn't mean anything. But then when you reinforce it, then it's external. And that's when I'm going to act more dramatically. Things that bring me comfort, I'm going to create. You're not going to often hand them to me. Okay? I can say all day long, well, you know, why don't you just sit, have a seat and relax? Why don't you just have a snack? Why don't you go for a walk? It's really not going to mean a lot unless I can come up with it. Or if I can do it with someone that I have a good connection with. Does that make sense? And then you're looking at boundaries again and the testing of those. You know, borderline personality disorder is hard. It's very hard because it's a no end kind of, for lack of a better word, like a no end game. There's no concrete resolution of anything. Okay, if I'm hungry, I'm going to eat. Okay, but for an example, I'm thinking of a client I had at Winnebago. If she was hungry, that could be a tool to accuse me of something. Okay, you don't provide me with things that are sufficient. I want things to be brought to me so you show me you care. Does that make sense? I mean, we're driven by our internal senses, and we can take care of ourselves. But often the internal senses are seen as a reaction to something else. Make sense? No? Yeah? I don't know what you're thinking over there. Okay. So the all or nothing thinking, that impacts on the relationship with clinicians. You either love me or you hate me. And if you love me, you're going to do things for me. And the concerning thing is that once you start you're going to get trapped very quickly, because the need to help by a lot of caregivers is going to reinforce the need to ask for or to take. Okay. So often when a staff crosses a boundary with a borderline personality disorder diagnosed client, it's because of that want to take care of or to help. Okay. Or because of fear. If you don't X, I'm going to kill myself. You know, it's a fear that, I mean, none of us want our clients to kill themselves. But if you go to the other extreme and see it just as a behavior and invalidate it, it might happen anyway. And it might happen anyway. But the boundaries are very touchy with someone with borderline personality disorder. I mean, very touchy. And I'm not going to say tread lightly. You have to tread firmly. Okay. Expectations outlined from the beginning and consistently are really important. Consistency, fairness, clarity on an ongoing basis are huge. Okay. If you tell me I can't do something on Monday and then you let me do it on Wednesday, game over. If an AM staff tells me I can't do something on Wednesday and a PM staff lets me do it on Thursday, game over. So consistency within a unit, a staff unit, is huge, because otherwise you're going to get that splitting again. And then there's going to be chaos. And it's not going to be with the client. It's going to be among the staff. So you have to be real careful about that. There's also a kind of a transient stress that staff can carry, kind of waiting for the next ball to drop. And that's real common. So if somebody acts real impulsively or intensely, and then they calm down, it's like, okay, I'm waiting. When's it going to happen again? What am I going to say? Or what's somebody going to say? So by treating each incident as an individual incident and not a continuation of the one before is really important, because you can be more concrete, you can be more consistent, and you can show more of a pattern of dealing with things individually, which is actually going to help. If I blow up at 10 o'clock and it's addressed by staff, and then I blow up again at noon and staff address it as a continuation of 10 o'clock, the escalation might go higher. The acuity might actually go higher. Does that make sense? If I address it as a individual incident and look for different triggers, chances are I might find them. If there's a statement of at 10 o'clock, you didn't let me do X, that's a different story. You might hear that. Okay. But still, there's going to be something a little different in each one. And it's because my self-image, it could be terrible, but it could be terrible for different reasons throughout the day. And not because somebody told me, but because that's what I perceive. Okay. So the other thing is that stress-related paranoia is not uncommon with someone with borderline personality disorder. And just by nature, there's that pervasive stress. So when there's that pervasive stress, you don't really know what's coming next, and you can formulate paranoia based on that. So if you were angry at me at 10 o'clock and somebody else gave you a hard time within the house at noon, I might worry that it's going to come back to me. Okay, and it's not paranoia like the FBI is after me. It's not the psychotic type of paranoia. It's a pervasive insecurity and stress-related response of when's the next bomb going to drop there. So it kind of goes both ways. Often the person will act really intensely in anticipation of that when it's completely inappropriate. And that's when you see those real explosive episodes and you're like, well, that wasn't even connected, or A didn't result from B. But they'll often name what's most recent. Does that make sense? If anything's not clear, say something. Okay. So there's also dissociation with trauma often. Dissociation, learning to recognize dissociation is important. Just when someone dissociates, chances are they're not going to move away from you. They're going to be there, but their attentiveness, their focus, their intention in their interaction with you is going to shut down. Okay. And people say that often you can get kind of a glaze. That's really kind of true, where it's just kind of like the door's shut. And you'll ask the person, are you with me? And they might go kind of a blank, yep, yep. And it's really, really, if you know what to look for, you can see it. And it's that disconnect in those areas, attention, intention, communication, and just kind of like, we all get distracted by thoughts. That's a form of dissociation. When I drive home and I don't remember the ride, that's a form of dissociation. That clinically, that's what that is. So paying attention to that is really important. So one thing that can help in working with people with borderline personality disorder is structure. Structure is huge because structure is predictability, okay, is consistency. So even if it's the predictability and the structure in meal times or times when you have to do chores, things like that, that's important because outside of that scheduled time, if somebody says to me, it's your day to do dishes, what do you mean? Why do I have to do them? But if 10 o'clock every morning or 8 o'clock every night is dishes, it's good. The predictability and the structure of that, it's going to take away the, why are you telling me to do that? Okay. So structure is huge. Predictability with regards to appointments, outcomes, consequences are big. Putting stuff in writing, it can help, but often how you put it in writing is different. So rather than a list of rules, depending, and look at the person. Like, for example, the client I'm thinking about that had the stuffed animals in her room, to make a list of goals or a list of expectations, they were in color. They were on an 8.5 by 11 piece of paper. They were written by her with staff, and they were posted on the inside of her door. Okay, so there's some kind of connection made. For me to hand you a list of rules, it's not going to be real meaningful. Okay, because it's going to be this is what you tell me I can't do because you don't like me, you think I'm bad. Okay, so it goes back to that internal system that I don't think much of myself anyway. It also goes back to the internal system of, in an abusive relationship, often there will be statements of, it was my fault, I should have done something. And just the victim role. In someone with borderline personality disorder, after they get out of the traumatic situation, that victim stance is often still there. And so there's different ways to work with that too. And while I'm thinking about that, therapy for someone with borderline personality disorder is recommended to be short term and very goal directed. It used to be where someone with that diagnosis would go into therapy and they'd have the same therapist 5 years later. Okay, and that is just really ineffective. The other thing that's ineffective is having like, I want to say, the more complicated aspects of like cognitive behavior therapy. Okay, if you have this thought and this is how you act, well, if you can change your thought to this or challenge that thought, that's a lot. Okay, so that's where DBT comes in, dialectic behavior therapy. And a dialectic is both an and. With someone with borderline personality disorder, you're dealing with black and white and yes and no and love and hate. And DBT teaches both and. Okay, and that's the dialectic. Okay, I could say, I care about you to someone with a borderline diagnosis, and they might think you love me and you'll never leave me. Okay, but if I couple that with, I care about what you're doing here, but I can't always be available. There's going to create that kind of more of a balance, and you're putting the expectation out there that I can't do it all for you. Okay. Some people don't even want to talk to a patient with borderline personality disorder about, I want you to do well, because they're so afraid of that, that attachment. But if you can do the both and, it's going to help. Okay. It completely challenges the concrete thinking of either or. Okay. So structure is helpful. Maintaining appropriate and supportive boundaries is huge. Appropriate boundaries means the agenda to meet the goal, not what I can give you or you can give me. We talked in the training about building a therapeutic relationship, about what's your agenda. Sometimes staff get caught in the crossing of boundaries with a borderline client because my agenda is to keep things as calm as possible. Okay, but that's my agenda. And for good reason. I mean, if you're running a group home and you have 8 to 10 clients, you don't want an atmosphere that's going to be explosive. But still, you can get in a trap that way because there's that boundary that's crossed. Okay, and it's hard. I mean, it's hard. So consistency is huge. Consistency in one staff on continuous behavior, consistency between staff is huge. And one of the biggest things that was a frustration at Winnebago was the difference between some staff than others. Okay. I told her no at 8 a.m. and this person let her do it at 2 p.m. And that ruins the process. It can ruin the process of learning. And it can also ruin the process of establishing. When we did the building of therapeutic relationship, we talked about the fact that the relationship is never even. Okay? It is always going to be like this because of the role that I play as staff or a therapist or doctor or caregiver or probation agent. It's never going to be even. Okay? So when boundaries are violated, it's often when people put themselves in the same relationship. Okay? You see that with, there was a staff at Winnebago, a nurse, who got really attached to a kid at YSU and left Winnebago so she could adopt him and adopted him into her own family. Okay? Yeah, huge. And then there was a staff that was just fired from Winnebago because he got in a sexual relationship with a client. Okay? And so for different reasons, that relationship comes like this. Okay? And there's no longer that, what do you call it? That difference, that role difference. And if I am a child and you take the role of my parent, think about it. In some way, we're still on the same plane now because we're family. You might be my mom and I might be the child, but we're family. So now we're back on the same plane. As a staff, if I'm a staff and you become my friend, we're on the same plane. And then the chance of crossing that boundary is going to increase. Okay. There's also concerning situations where if a staff, and I saw this at Winnebago, is that if a staff feels themselves coming to cross the boundary, they'll react very strongly the other way. And then there might be targeting behavior. You're always breaking the rules, some almost targeting, looking to correct the wrong that they recognize themselves getting into. So if I'm constantly on your back, I'm going to create distance. And of course, nobody would see that boundary is crossed. And then I'm safer. Okay. And it's going to help me not cross that boundary too. You know, anger and fear are great motivators either way. Okay. If I'm responding to your fear in a supportive manner and I talk about similar fears that I have, you're in trouble. If someone gets really angry and I justify your anger instead of supporting another staff, you're in trouble. Okay. And I think this is probably one of the most difficult diagnoses to work with. But in saying that, I've seen some really positive change. And as a therapist, doing the shorter term therapy, it's really a lot more effective because it's very concrete and it's very clear. In DBT, you focus on two things. You talk about skills training and you do chain analysis, what's called chain analysis. In skills training, it's emotional regulation, you know, it's skills within building relationships, making your needs known, incorporating logical mind and emotional mind together. So that it's not so concrete. Because if I am a clinician, I tend to go on the side of logical, factual, okay? If I have borderline personality disorder as a diagnosis, I tend to be driven by emotional, okay? If I show you support, I'm coming from an emotional part of my mind, and I'm trying to balance that with the logical by being concrete, but supportive and consistent, but therapeutic. I'm finding that middle. Okay, the expectation is going to be very similar of the client, but come in the other direction. So if the person is really emotional, you want to insert facts that might challenge that, okay, or balance it. Does that make sense? You know, I tend to be more logical. The client that I was talking about with the stuffed animals in her room, she tends to come from emotional. So my skills with logical can really help bring her back to center. Because facts are concrete, okay? Thinking with someone with borderline personality disorder tends to be concrete. So consistency, concreteness, factual behavior, or factual information can actually help. Chain analysis, when a patient who is diagnosed borderline personality disorder acts out, a really helpful tool is what's called chain analysis. Normally, when something happens, we say, well, what caused it? You know, and we go way back here and what caused it? What caused it? What caused it? And chain analysis does the opposite. So if I act out at 10 o'clock, well, what happened just before that? What happened just before that? What happened just before that? It's a backwards chain of events. Okay, and it is much easier to identify the triggers because it's closer. So if I blow up in the kitchen at 10 a.m., what happened before that? Well, you know, you didn't want to let me have this for breakfast. Well, what happened before that? Well, somebody was in the bathroom when I had to go, and I needed to go just then, and I had to wait. Well, what happened before that? I didn't sleep real good. Well, what happened before that? You know, my mom didn't return my call last night. What happened before that? And it doesn't go on forever. You'll be able to identify, bang, this is when it started. And just in that example I gave you, mom not returning my call is huge. Okay. So if you go, what happened before that? I called my mom. Chances are right here is where it started last night when my mom didn't call me back. So that's why it's really helpful to go backwards, because it's easier for me to remember that I didn't get what I wanted for breakfast first rather than, well, my mom didn't call me last night, and so I was still mad this morning. That-
Really insightful to think that far back too, like even without the diagnosis, you
Mhm.
could go back and say, I'm in a really, really cruddy mood today
Because
because
of,
of something that happened last night. I don't know that I would even necessarily go to that immediately. It would probably be, well, I wanted Oreos for breakfast.
and it's not accurate. If I say I'm really crabby today because I had a terrible day yesterday and I ended up working until 6 o'clock, that's probably not it. You know, that's probably not it. It might be one of the triggers, but by going backwards, you're going to more easily identify what it was. And do it very actively with the client. Have them come up with the answers. You don't come up with the answers, but you put it on paper. So if I start with the explosive incident and I go backwards, I make a loop and I go backwards on paper. And each loop is the circumstance. Okay, just like a chain, just like a chain, just like a chain. And then that client keeps that piece of paper and you title it, okay, and you use it as a very concrete tool, okay. So I find those really, really helpful. So one thing, just lastly, predictability, consistency, and fairness are huge. And working together with staff to be informed on somebody's history is huge. Okay. Don't assume that if somebody's diagnosed with borderline personality disorder that they have a sexual abuse history. It might be a pretty good chance, but it might not be that. It might be some other kind of trauma. Okay. It might be abandonment. It might be neglect. It might be, it could be a variety of things. And it needs to be addressed separately in interaction from a psychiatric illness. Okay. So if somebody has bipolar disorder and they act impulsively, it's going to look different than if somebody has borderline personality disorder and they act impulsively. Because with bipolar disorder, often there's less of an emotional connection to the impulsivity. It's just when I want, I want. Okay. Or when I have borderline personality disorder, the impulse is often driven from emotions, not not stimuli, like physical stimuli, like shopping or gambling or, things like that. So that's something to keep in mind too, that look at those things differently. Okay. Learn about the diagnosis. The DSM-5 actually explains it pretty well, and I think better than the DSM-4. But don't get your head all trapped in that either, because everybody's going to present just a little different. So, most importantly, on the bottom of the paper, I said, be kind, and I think we all just need that. Being kind doesn't cross a boundary. It just, it's just kind. So, okay. Any thoughts? Oh, there's somebody else on. Who else is on here? Linnea. That's you. But there's and Eric. I thought there was one other person. I guess not. Okay.
Eric's here. Did it, Eric?
This conference will now be recorded.
Now that I left.